Let's go ahead and start off with introductions. Jerry, you want to start off, please?
Yes, thank you, Mr. Chairman. Jerry Sloan.
Yes. Good enough.
You want to say any more?
No.
I'm Representative Helgerson, and I just want to say, Tax Committee is meeting down the hall if you want to break out and go back down, since you used to chair that.
Need help?
We need lots of help, but I'm from Wichita, so.
Dennis George with APS and work with the hospitals in Kansas from Ottawa.
I'm Dr. Craig Kincannon. I'm chairman of the Healthcare Stabilization Fund.
I'm Marvin Klebb. I'm semi-retired as well from Overland Park.
Will Carpenter, District 75.
I'm Daryl Conradi from Conradi Insurance in Newton.
Doug Gleason, I'm an OBGYN here in Topeka.
Thank you. Leanne, you want to start off? Can you have your team introduce themselves, please?
I was just going to keep going into the meeting. Hi, I'm Leanne Thone. I'm a senior research analyst for KLRD.
Randy Walters, committee assistant.
Good morning, committee. I'm Jenna Moyer, and I'm an assistant revisor with the Revisor of Statutes Office.
I'm Edgar Klein. I'm a fiscal analyst with KLRD.
Julia Kofoid, research analyst with KLRD.
Good, thank you. We appreciate all the work the staff goes through to get us going here. So let's start off. Leanne, go ahead, and we're now ready.
Good morning. Again, my name is Leanne Thone. I'm a research analyst with KLRD. I'm just going to go through what's in the folders quickly so that you know what's in there. The first item is the agenda. It's on yellow paper. And then there are 3 documents from KLRD. The first is the interim committee report from this committee from last year, 2024. The second is the Healthcare Stabilization Fund appropriations report for fiscal year 26. And then the Healthcare Provider Insurance Availability Act statutes. Then there is a reviser's document that Jenna will present. And the binder clipped document is 3 parts. This is the Healthcare Stabilization Fund actuarial report, the fiscal year 25 claims activity, and the statutory annual report. And then the rest of the documents are testimony from stakeholders. So there's a document from CAMCO, a document from the Kansas Medical Society, and I apologize, that's also testimony from the Kansas Hospital Association. I didn't get that on the agenda, but it is joint testimony. And then there are 3 documents that are written only. One from the Kansas Academy of Physician Associates, one from the Kansas Trial Lawyers Association, and a late edition that is not on the agenda, but is written only testimony from the Kansas affiliate of the American College of Nurse Midwives. So that's all the testimony in the folders that you have this morning. And just as a reminder, if anybody is listening online, this meeting is being broadcast on the legislature's audio video stream and YouTube page. And testimony is available on the committee's page on the legislative website. So you can access that if you are watching us remotely at ks.gov.
Thank you, Leanne. Appreciate it. Next, we have Jenna Moyer from the Revisor's Office.
Good morning, committee. And you should find in your folders a document that looks like this that we'll go over. Oh, I probably did that kind of fast. That we'll just go over the highlights from the 2025 legislation related to healthcare, and especially this committee. The first of those is Senate Bill 29, and that bill removes the authority of the public health officers to prohibit public gatherings to control infectious or contagious diseases, and would prohibit a local health officer or the Secretary of Health from ordering law enforcement to assist in the execution of orders related to isolation, quarantine, or treatment of infectious or contagious diseases. And the changes in KSA 65101 would also allow any aggrieved party or any party aggrieved by a public health action taken by the secretary or a local health officer to file a civil cause of action. It sets out some court requirements on the timing of those hearings, and then the court would be required to grant the request for relief unless the order, in this case, the public health order, meets a strict scrutiny standard of review, which means that the order is narrowly tailored to the purpose stated in the order and uses the least restrictive means to achieve such purpose. And the second bill would be a Senate Bill 63. It prohibits providing gender-affirming care to minors, and it was passed as the Help Not Harm Act. And the relevant portions of this bill prohibit healthcare providers from performing certain surgeries and prescribing certain drugs to children as a treatment for gender dysphoria. And there are exceptions laid out in Section 3. But if a healthcare provider is found to have violated this prohibition, the license of the provider shall be, meaning there's no discretion allowed to the licensing agency, that the license shall be revoked by the provider's licensing or governing entity. Section 4 of the bill provides that a healthcare provider who provides the prohibited treatment to a child will be held strictly liable. And that's a legal standard that makes a defendant liable even without clear indications of negligence or intent to harm. If I think back to law school, we had the ABCDs of torts, which was a duty, breach, causation, and damages, and strictly liability would sort of just assume those first three, the duty, breach, and the causation. So essentially, you'd just be required to prove damages in this case. So the provider would be held strictly liable for any physical, emotional, or physiological harms to such child 10 years after the child turns 18, so up to the year that that child turns 28. The parents of a child who received the prohibited medical treatment also would have a cause of action against a healthcare provider who provides this treatment. Section 5 of the bill prohibits professional liability insurance policies issued to healthcare providers from covering damages assessed against provider claims that resulted from these prohibited treatments. And the next bill is Senate Bill 67. And that bill allows certified registered nurse anesthetists or CRNAs to prescribe, procure, and administer any drug or durable medical equipment consistent with the CRNA's education and qualifications, except for anesthetic agents that require the order of a physician or dentist. You may remember when we expanded the authority of just your average AR of nurse practitioners. The corollary was not done for nurse anesthetists, so this bill would come in and allow them the same prescriptive authority as nurse practitioners. And a CRNA would be required to include relevant information on prescription orders and to comply with federal DEA requirements related to controlled substances. Next bill is Senate Bill 250, which was the Right to Try for Individualized Treatments Act. It would allow a manufacturer in an eligible facility to make individualized investigative treatments available to individuals with life-threatening or severely debilitating illnesses. The act requires written informed consent be provided to the patient. It does not expand required insurance coverage for those treatments. The act would prohibit a licensing board from disciplining a healthcare provider based solely on that provider's recommendations to a patient regarding treatment with one of these individualized investigative drug products or devices. The act also does not provide a private cause of action for harm covered by one of these covered products, devices, or drugs if the person or entity, so the healthcare provider or the manufacturer, acted in good faith and with reasonable care. And the last bill we'll go over is, it's sort of a omnibus healthcare providers legislation. This was House Bill 2039. And in an issue that will be very familiar to this committee, it amended the definition of healthcare provider in KSA 403401 to include a maternity center, which would allow the maternity centers to access the Kansas Availability Plan. This bill also amended the definition of home health agency to exclude certain entities that would only provide physical therapy, occupational therapy, or speech-language pathology service. House Bill 2039 also made changes to EMT or emergency medical provider statutes to clarify the authorized activities of paramedics, advanced emergency technicians, and EMTs. The law would permit ambulance services to provide only non-emergency transfers to operate less than 24 hours a day, 365 days a year, and also authorizes ambulances operating in counties with a population of less than 30,000 people to operate with one person who is an EMS provider or higher, as long as the driver is certified in CPR. And I will be happy to answer any questions about these bills.
Do we have any questions? I see none. Thank you. We're now ready for the actuary reports from 2024 to 2025. And go ahead. Welcome to the committee.
Thank you, Mr. Chairman. Good morning, everyone. Russ Sutter from the consulting firm WTW. You should have a copy of my presentation in your materials. And just sort of as an outset, two things I'd like you to keep in mind while I'm going through this. First is sort of the timing of the process here. What we're reporting on to you today is an analysis of data as of year-end 24. We do that analysis in January, February, early March, make a report to the Board of Governors at their March meeting, and then the board considers our report when setting rates for, in this case, calendar year 26. So while we have some information on data for the fund after December 31st, most of our analysis is based on December 31, 2024 data. Secondly, and perhaps more importantly, is to keep in mind the significant changes in the fund that took place with the legislation that became effective in calendar year 22. And as a reminder, here's what happened. Back in 4 years ago in calendar year 21, the fund was picking up excess of $200,000. In other words, if there was $1 million claim, the primary carrier picked up the first $200,000, the fund picked up from $200,000 to $1 million. Beginning in calendar year 22, and with claims occurring in 22 and subsequent, now the primary insurance company picks up from 0 to 500,000, and the fund picks up from 500,000 to $1 million. So as a result, the fund was able to lower its rates because it's providing less coverage starting in 22, and the liabilities of the fund are coming down because it's paying out less on these $1 million claims. So in a way, the fund is shrinking. And you'll see the results of that in several of the slides that I'll be presenting. So again, something to keep in mind about the change in the fund, which is material today versus what we were looking at 5 years ago. So moving on to page 1, what we'll be talking about are a quick sort of summary about the fund's revenues and costs over the last quarter of a century now. Where we think the fund's position is as of June of 25 and a forecast for June of 26. What we think the fund needed to do for its rates for calendar year 26 to maintain the same level of a solvency that it has today. Some comments on the fund's investment returns, some comments on transfers to the availability plan. Looking at results by the type of provider, where some providers are not paying enough to cover their costs, while others are paying perhaps more than their fair share. And then finally, some recommendations that we made to the board and their eventual decision about how rates will be changing come another month and a half. And finally, if time permits, I'll draw some comparisons with the Kansas fund to the comparable fund in New Mexico, as I've done over the last couple of years while presenting to this group. Happy to take any questions anyone may have. Otherwise, if we could go on to slide 2. And thank you. So here we show, starting in 1999, the fund's revenues in the sort of darker line, and our estimate of the fund's costs of providing coverage in that year in, call it the pink line. And so you can see, going back to 1999, at that point, the fund was collecting only about $10 million a year in surcharge revenue. And the costs in that year of providing coverage was about $23 million. Simply to illustrate how the chart works. Now, there are elements of the fund's financials that aren't captured in this chart. For example, on the revenue side, we're not picking up the investment income that the fund earns. And on the cost side, we're not picking up the fund's administrative expenses or any transfers to KDHE or the availability plan. So it's not a perfect analogy in terms of if one line's above the other, then we're making money or not making money. But these two lines should move kind of in parallel over a long period of time. And of course, as mentioned a moment ago, with the big change in the fund law 4 years ago, you can see how the fund's revenue came down considerably from 21 to 22, and how now we're seeing the fund's costs come down as a result of the change in that law. So again, just to keep in mind the fund's history of revenues and costs over the last 25 years. So, calendar year 24 was kind of mixed from our perspective. Moving on to slide 3, payment activity was fairly high. Loss performance on active providers was a little worse than we had predicted, particularly on defense costs. However, loss costs on inactive providers did better. Investment results were a little better than in 23, but still seemingly a little lackluster. Transfer to the availability plan was unusually high in calendar year 24. And the relative rate inadequacy, and we'll talk about this later on, for the hospitals remains high. In other words, we need to raise rates on the hospitals by 31% just to get them back to average for the fund. But it is down from where it was a few years ago when it was a 61% rate increase was needed. The fund's financial position at June of 25 was a little better than we thought a year ago, and we'll show those numbers in a moment. But there remain 4 areas of concern for us. The first is the overall rate inadequacy is creeping up a little bit. The rate inadequacy of the hospitals remains fairly high. Investment returns continue to be a little lackluster. And finally, if payments to the availability plan continue to be one direction. In theory, we'd like to see some of the availability plan money coming back to the fund, but now we're looking at 8 years in a row where the availability plan has had to accept money from the fund to shore up its finances. So those are our areas of concern that we'll be touching on through the remainder of this presentation. In terms of the overall conclusions on the Am I pushing the wrong button here, or is it? Oh, you've got it. Okay, slide 4. Here we're looking at the fund's balance sheet. What we predicted last year is in the first column for June of 25. What we are now predicting, or had predicted this year, for the June 25 balance sheet. And in the right-hand column, what we're going to tell you next year at this time for June of 26. So a year ago, we thought the fund would have assets of $259 million as of June of 25, liabilities of basically 236 for a net surplus or unassigned reserves of about 23 million. As I mentioned a moment ago, the position's a little more favorable than we thought. We're now, in our this year's study, we have the assets coming in at about 260, so slightly higher. The liabilities slightly lower, so we're actually in a better financial position than we thought a year ago by about $900,000. Now, here's where the change in the fund law comes into play. You can see for next year, we're expecting both the assets and the liabilities to be $7 to $8 million lower than they are today. Again, that's due to the change in the fund law where the fund is picking up less coverage than it was 5 years ago. And we expect this sort of shrinkage of the fund to occur for a few more years until all of the claims that are subject to the 200,000 attachment point are taken care of, and we're only left with the claims that are excess of 500,000. So we're calling next year's numbers to be a net unassigned reserve of about 24.5 million, less favorable than we think exists today, where it's about 25.3 million. If we can move on to slide 5, and continuing with those conclusions, again, what do those numbers assume? The next year's numbers reflect a 3.1% increase in the surcharge rates that become effective January 1st. We think the fund will collect a little under 22 million in revenue in the current fiscal year, fiscal 26. 2.6 yield on the fund's assets, and we'll go over that history and implications of it in a moment. There'll be a transfer to the availability plan of 800,000. We'll continue to get full reimbursement on the KU and WIGME claims, and no changes in current Kansas tort law or fund law. So when we presented this information to the board back in March, we gave them a couple options. We thought an increase in rates for calendar year 26 was warranted, particularly for the hospitals class. And given the rate level indications, we did not think that a 0% change or no action was appropriate. And we were glad to see that the Fund Board of Governors did approve an increase in rates effective January of 26. We can move on to slide 6. A moment ago, we were looking at the balance sheet, and now we're going to turn basically to the income statement of the fund for what we think will happen in calendar year 26. First, we think the payments for settlements and defense costs, net of reimbursements from the KU and WIGME programs, will be about 31.4 million. Again, because the fund is getting smaller, the liabilities of the fund in calendar year 26 will come down by about 5 million. The fund will incur administrative expenses of about 2.6 million, and there'll be transfers to the availability plan and KDHE of about 200,000 for total transfers of $1 million. So row 5, you can think of what's the cost of the fund staying in business next year. And so we've got that at about $29.9 million. So how's the fund going to finance that $29.9 million? Well, there are two sources of revenue. The fund has at its disposal. One is the investment income that it's going to earn. And we think that's going to be about 6.5 million based on a 2.6% yield on the fund's assets. So whatever it doesn't get in investment income, it's got to get from surcharge revenue to break even. And if it's going to earn 6.5 million in investment income, that means it's got to collect 23.3 million in row 7 to break even. We don't think it's going to do that. Without the rate change that's going to be implemented in January, the fund would have earned, in our estimate, 21.5 million. So since it needs 23.3 and it's only going to earn 21.5, that means it's got a rate inadequacy of about 8.7%. If there are no questions on that, we'll move on to slide 7, the fund's investment income. So what we show here are the fund's investment returns relative to its assets beginning in fiscal year 24. And so if you look at fiscal year 24, we had average assets, average of the beginning of the year and the end of the year assets of about 264 million. And the fund earned investment income net of investment fees that year of 9.3 million for an effective yield of 3.5%. And you can see how that yield came down year over year considerably until it bottomed out temporarily in 2019. And you can also see how the fund was still growing at that time by the change in column 2, peaking in 2022 at 312 million. Because of the change in the fund law, as I mentioned, the fund is now shrinking, and the average assets in calendar year 25 were a little under 270 million, while the fund's investment income was about 7.1 million. So it's interesting to compare 2014 to 2025 because the average assets were about the same, between 260 million and 270 million. But the investment income was considerably less, 7 million versus 9.3 million. So last year's yield, 2.6%, and we're assuming that will continue over the next year. One could argue both sides of that. Again, the yield has been coming up over the last couple of years, so maybe it'll go up in '26. On the other hand, the Federal Reserve has taken down short-term interest rates, I believe in each of their last 2 meetings, by 25 basis points. So clearly the direction is not going up with those rates, it's going down, but those, of course, are short-term rates. And I think the comment at the bottom of the page is particularly relevant in terms of the implications of these investment returns. Every 10 basis point change in that assumption is worth 1.3 points in rate level. In other words, we're assuming 2.6%. If the fund could earn 3.3% instead of 2.6%, that rate inadequacy that I mentioned a moment ago of 8.7% goes to zero. So that's the implications of the investment income. Every 10 basis points that it can earn knocks a point to a point and a half off of that rate inadequacy situation. Any questions on the investment results?
Mr. Chairman, is this the appropriate time to discuss the investment income or later with the fund executive?
I'm happy to entertain any questions you have. If I can't answer them, I'll defer to the others.
As we looked at last year, we made a comment from an oversight committee to look at the opportunities to possibly increase. As I pondered this over the last year, when we look at the great state of Kansas and the fact that we have many governmental entities from school districts to county issuing debt at a higher rate than 2.6, and I know we go through the MIP to do these investments. Is there any opportunities when I look at a Johnson County School District bond or anything to up our rates, which are still guaranteed by a GO bond, to be able to increase the rates to maybe 3%?
I'm not in a position to answer that. I think what's the name? PMIB would be the person to answer that. But it just strikes me that I'm earning 4% on a CD. I'm a rather miniature investor. It would seem that there are opportunities to improve that yield.
And when I look at the CAPERS program, they're running close to 7.9 to 8%. So again, different structure, different issue, because we want to protect the communities and the patients from any inappropriate medical care. But I'm just looking at when I see all the new GO bonds being passed, could that be a way to get closer to that 4% like we can on some? And so again, Clark, I'll save that for you.
Any other questions? Yes, no problem. Yes, Representative Carpenter.
Thank you, Mr. Chair. So we had that discussion last year, and I'm looking through the report from last year about, so is there any legislative blocks, maybe you'll be able to answer this, but are there any legislative blocks to keep us from investing that money that we need to do as far as a bill or anything like that?
My understanding, there are restrictions within the legislature on what the fund can invest in. And Mr. Schultz, I don't know if you want to address that now or wait till your turn.
Well, let's just wait then. Let's just wait if you're going to, Clark, if you're going to.
We'll pick up on that conversation when Clark gets up. Yeah, good.
Thank you,
I
Mr.
just want to point out the implications in terms of, you got to get the money from somewhere. You got two sources, the medical providers or the investment returns.
Go ahead and continue, Mr. Sutter.
If we could go on to slide 8 then, please. So transfers to the availability plan. Now, this was candidly an item that I had not paid too much attention to years ago because it seemed to be kind of a wash over the long term. That is, if the availability plan had a profitable year, they'd give money back to the fund. If the availability plan had an unprofitable year, the fund would cover that and send money over to the availability plan. And over years, it seemed to be kind of insignificant. Some years it'd go one way, some years it'd go the other way. But in the long run, it wasn't a material issue to the fund's financials. From my perspective, that has changed, and this slide demonstrates it. If you look at, for example, 2019, just to illustrate what's being shown on this page, in 2019, fiscal year 19, the fund transferred to the availability plan 552,000. The fund's revenue that year was 28.9 million, so that plan transfer amounted to 1.9% of the fund's revenues. A couple of years here are pretty insignificant, 21 and 23, but now you see in column 3, the fund's revenue is coming down because of the law change, and some of those transfers are getting to be pretty significant, most significantly, obviously, in fiscal year 25, where it was over 3.8 million, representing 18% of the fund's revenue. I learned earlier today that in the current fiscal year, there's going to be another transfer to the availability plan, something around 600,000, so that'll make it 8 years in a row in which the money has gone from the fund to the plan. And we need to build this into our rate analysis for the fund. If it's going to keep sending money out the door, then we've got to make sure that the fund's revenues, at least its revenue needs, anticipate this. And so we've ramped up how much we're building into our rate indications for this cost. We were assuming for several years that it was only going to be $100,000 a year going from the fund to the plan. Looking at this chart, that seems like an optimistic assumption, and so we ramped that up to 800,000 this year. And 800,000 on a revenue base of 20 million, that's 4% of the fund's revenues that's going to the availability plan based on that assumption. Any questions on the availability plan? If not, we'll move on to slide 9. And here our focus changes not from a total fund perspective, but from an individual provider's perspective. And at this point, it may make sense to take a quick glance at the final slide of the presentation, slide 12, if that could be brought up. For those of you not familiar, every provider is slotted into one of 24 classes, as shown on this slide, with our definitions. These aren't the official definitions of who goes into each class. This is sort of our shorthand for it. How many providers there were in calendar year 24, and what the rate is that they're paying to the fund in calendar year 25. So for example, class 2, one of the biggest classes in the fund, generally physicians, no surgery, a general internal medicine person going there. We've got over 5,000 of them, and this year they're paying the fund $788. Whereas class 17, the medical care facilities, not a large number, but big dollars on their surcharge revenue, 201 of them, and they're paying 19% of their basic coverage underlying premium. So every provider is now slotted into one of these 24 classes, and this class system has existed since 1999. Now, if we could go back to slide 9, please. So we look at the experience by each class to figure out if some classes are adequately rated, that would be the middle column, not paying enough relative to their costs, that would be in the right-hand column, or paying perhaps arguably more than their fair share in that left-hand column. From our perspective, we'd like to see every class in that middle column, that if you're incurring 10% of the fund's losses, that then you'd be paying 10% of the revenue. We've made some progress on that over the years, but we still have, from our perspective, a lot of classes in those left and right-hand columns that we'd like to squeeze into the center. And we point out some of the extreme situations here. For example, on the right-hand side of the column, class 17, the hospitals, they have a rate inadequacy relative to everybody else of 31%. Whereas on the left-hand side of the page, class 22, they're paying arguably more than their fair share, and their rate relative to everybody else could come down by 33%. So the point here is if the fund were to do no overall change in revenue, but just sort of try to get everybody evened out, they'd be taking the rates down on the left-hand side of the page classes and raising them on the classes that are on the right-hand side of the page. And so when we're recommending potential changes to the Board of Governors, we might say, hey, you might want to take up Class 17 and you may want to take down Class 2, just to even out the equity within the fund from a provider's perspective. Because again, our objective, public policy issues or social issues aside, would be to get every class into that middle column if we could. If there are no comments or questions on slide 9, we'll move on to slide 10. Again, just some more background on what the fund has done with its rates over the last dozen years. You can see in the overall change column for 2013, in that year, the fund lowered its rates by 5% and had a range of changes with a low of some classes getting a 10% decrease, others getting no change. And you can see over the next 7 or 8 years, the changes were fairly modest overall, a couple small positives, a couple small negatives. Then in calendar year 22, and as a result of the law change, fund surcharge rates came down significantly to reflect the projected lower costs of that law change. In calendar years 23 and 24, there were overall 0% changes, but with some changes in 24, beginning in 24, of modifying the rates by class. And finally, for the rates effective this year, again, there was an overall 4% increase, with some classes getting an increase as much as 8%, others getting some decreases. So again, just to keep in mind the decisions that the Board of Governors have made with its rates over the last dozen years. Moving on to slide 11. When we presented to the board in March, as we usually do, we provided a few different options for them to consider in establishing rates for 26. All of those involved an overall rate increase and a rate increase to the hospital's Class 17. After some deliberation, the board decided to raise rates by an average increase of 3.1% based on taking rates up for 10 classes, ranging from as low as 3% to classes 8, 9, 10, and 11, to as high as just under 10% for the hospitals. Took rates down by 2% for a couple of classes, and you'll notice those classes that are listed there are those that are on the left-hand side of the page that we talked about moments ago. And there'll be no change in rates for 10 of the classes. So again, an overall rate increase of 3%, ranging from a decrease of 2 points to an increase as high as 10 points on Class 17. We thought this was a very reasonable action, helps the overall fund adequacy situation as well as the rate adequacy by a provider perspective. So that's what's going to take place in calendar year 26. And finally, as I mentioned at the start, I'd like to make some comparisons with the comparable funds in New Mexico. So if we could turn back to slide 4, please. Thank you. So if we were to look at the New Mexico Patient Compensation Fund as of year-end 24, just to compare to where the fund is versus a comparable fund in another state, their assets at year-end 24 were $308 million, and their liabilities were $342 million, as estimated by their actuary. So they're in the hole by $34 million as of year-end 24, whereas the fund is positive in the green by $25 million. But that's only part of the story. Because again, $308 million of assets, $98 million came from transfers from the General Assembly. In other words, taxpayer money. Absent that $98 million infusion from the taxpayers, they'd be in the hole by $132 million. So that's what can happen when these funds go awry. The fund has never been in that position, at least since I've been involved, and I'm pleased to say we don't anticipate that happening over the next year or two. But again, other states are not in such a similar situation and have had to use the taxpayers to even only partially bail them out in terms of their financial position. So, Mr. Chairman, members of the committee, that concludes the prepared remarks. I'll be happy to take any further questions any of you may have.
Thank you. Committee questions? Yes, Mr. Slaughter.
Thank you, Mr. Chairman. Mr. Sutter, thanks for the report. Full disclosure, I also serve on the Healthcare Stabilization Fund Board of Governors. And as a member of that board, I thought it would be important to provide a little additional context to Mr. Sutter's remarks about the disparities in the different rate classes. And Mr. Sutter's exactly right. He's been bringing this analysis to the board for a number of years. And the board has a committee that studies this. They've been doing it for the last 3 years, I believe, Clark, 3 or 4 years. And they've chosen an approach that they realize there are some inadequacies in some rates, some a little high, as he said, and some low, as he has said. The board has elected to gradually begin to rebalance that. In other words, instead of a few years ago, the hospital inadequacy was about 60%. That's sort of a rate shock to a hospital, particularly when margins were already stressed and the economy was suffering, a few years ago. The board felt to do it all at once wouldn't be appropriate. So they've chosen, and I give credit to the hospital community because they've had to absorb pretty large increases for each of the last 3 years, and there's probably another one coming. But we have gradually tried to eliminate the disparities there. We've taken, for example, the hospital inadequacy from about 61% down to the current. We've cut it in half, basically, in a few years. And so I think the board has addressed this and will continue to address it. Mr. Sutter's been very helpful in helping us analyze different scenarios. And I think the point is not to shock any one class with a substantial rate increase, but to spread it out over years and try to get back to what he said where we should be, moving everyone to that central column. So, Mr. Chairman, I just wanted to provide that as context to his remarks.
I was wondering that myself. So that's good. Representative Carpenter.
Thank you, Mr. Chair. So on page 11, the rate increases, the surcharge rates, how much will that bring in?
The 3% increase would generate about between $600,000 and $700,000 of additional revenue to the fund.
Okay, so this page would be about another 700,000 then, is that what you're saying?
Yes.
Okay. Thank you. Thank you, Mr. Chair.
Any further questions? Seeing none. Thank you, Mr. Sutter. Appreciate it.
Thank you.
Committee, next we have Steve Lewald from the General Counsel. Welcome to the committee.
Thank you, Mr. Chair. My name is Steve Lewald. I'm General Counsel at the fund, and I'm going to go over the medical professional liability experience fiscal year 2025. If you look in your information, it looks like that there. So first, I'm going to talk about the annual claims report. And this report pertains to those claims where the fund provided excess coverage for the Kansas healthcare providers and also tail coverage for the inactive healthcare providers. And just a caveat here, this report isn't going to dovetail with the budgeting or actuarial reports because it's going to reflect monies incurred for claims settled during the fiscal year. And the other reports are going to examine the monies actually paid during that time period. This report does not reflect expenses paid to defend the claims as well, such as attorney's fees. It's more of a snapshot of the claims that the fund was involved in for the previous fiscal year. Prior years are listed for comparison purposes. The specific data may have changed because sometimes we have court proceedings or multiple years where we have to provide payments. So 3 areas I want to focus on here: trials, settlements, and then new cases. If you go to page 2 of that report, we're going to talk about the trials. This past fiscal year, there were 17 trials, and they involved 21 Kansas healthcare providers. And the discrepancy there would be sometimes, for example, if you get a hospital and doctors involved in a case, then there's going to be more than one potential claim involved. Throughout the year, we had 14 defense verdicts, 2 plaintiffs' verdicts, a split verdict, and then a hung jury. And then you look there over the past 10 years, that's right about the average number of trials. You had the anomalies in 2021 because the courts were closed for a large chunk of time. And then 2022, when you had a few more of the plaintiff's verdicts, I think what we had was plaintiff and defense counsel kind of feeling things out post-COVID and see how things were going. So that would explain that. The trials are pretty well spread out. You saw 5 in Johnson County, 5 in Sedgwick, and then 2 each in Shawnee, Wyandotte, and Clay County, Missouri. Why would we put Clay County, Missouri in there? Because if we have a healthcare provider that's actually residing in Kansas, but they're working or providing care in another state, then we would follow that as well. So you get a lot of that on the state line there in the Johnson County and Jackson County and Clay County area. So that would explain that. And then we had 1 in Dickinson County as well. Overall, I'd say we're trying the cases that need to be tried. As long as you have a team that's willing to do so, you need the doctors involved, the primary carriers all have to be involved, but we feel like we push back when we can if we feel like there is, a valid case to be tried. Moving on to page 3, talking about the settlements there. Just a reminder, this information concerns claims settled by the fund, the excess of the primary insurance carriers limits, and then claims against inactive healthcare providers where the fund has that first dollar tail coverage. For the fiscal year 2025, the fund was involved in the settlement of 95 claims for a total of $27.7 million. If you look at kind of that comparison for the 10 years before, it has gone down. And that would make sense because we're starting to see more and more of the 500 claims versus the 200, 800 claims. So that's starting to bear fruit there. And that just kind of shows you the settlement average of $292,000 per claim. That's just for the fund, what it's involved in. There were more claims in the previous fiscal year, but like I said, a lower fund obligation, so we're okay with that. If you go down to the bottom of the page there, it talks about the primary carriers and then the excess carriers as well. Of the 95 claims that the fund was involved with, the primary insurance carriers tendered their policy limits to the fund in 74 of those claims. And by tendering, that just means they review the case and determine that it's going to be in excess of what their coverage limits are. And they decide, you know what, okay, fund, you go ahead and take over. So at that point in time, we are responsible for providing defense and kind of going through all the different issues of the trial or settling the case. And then you'll see that, so you'll see 2025, $37 million approximately for primary carriers, so that's quite a jump, and some of that makes sense because we're switching more and more from the 200, 800 to 500, 500, but part of that may just be, we're getting more claims and more cases involved. And then the excess carriers at $15.2 million, that's quite a bit of jump as well. And I will just say, looking through the cases, I think we had probably 4, maybe 5 cases where they involve birth injuries. So if you have a child that's born and has issues, that can be a lot larger claim because, they have future care that they're going to need to deal with. So it gets into that excess layer, which is beyond the fund. So if you think of levels, you got your primary carrier, the fund would be that second level, and then the excess carriers are going to be that third level. So they paid out more this past fiscal year. And we'll move on to the next page there, page 4. And that just talks about some of the different severity of claims as far as the fund involvement. So you can see there as far as, the range that we're looking at, we had fewer in that 600,000 to $1 million range, which would make sense because we are getting fewer of the 800,000 fund involvement. So that reduced, but then you see the 250,000 to 600,000 that bumped up, which would also make sense because we're going to have more of the 500 versus the 800. I think that's it for there. And then finally, new cases by fiscal year, that dropped down almost 50 cases from the year prior. So we're getting, at least this previous year, we had fewer cases, but I feel like some of them were kind of larger, maybe bigger cases that took more time. Any questions on that part of it?
Mr. Chairman, may I ask one question? Could you tell me on the two verdicts last year, were those Missouri or were those Kansas verdicts to the plaintiffs? And again, because being in the metro area, working with hospitals that are on both sides of the state now.
Yep.
More of our physicians are going to be working both sides.
Yep, so one was Missouri, that Clay County one, and it was a nursing home case, relatively low value. I mean, 30,000 to 40,000 was kind of the amount, so it didn't even get to the funds level. It's just one of those cases that had to be tried when I was talking to defense counsel on that. The other one was in Johnson County, and that was a bigger case there to the tune of $5.7 million, but that is still going through kind of post-trial motions, and both sides are kind of figuring out what they're going to do on that case. I believe the representative from CAMCO may talk a little bit more about that. I'm willing to talk more about it if you'd like.
No, just my curiosity, Steve, because again, watching the metro, watching the history of which sides people have filed on with the metro claims. And
Yeah.
it's very interesting. Missouri has been very more plaintiff-friendly.
Yes, and on the Kansas side, we're seeing maybe some more cases that might have to go to trial in Johnson County and Wyandotte, and that's just kind of I'd say the nature of the beast, just because, you get plaintiffs' counsel and they're getting good and better, and they're finding cases that are difficult, so.
Thank you very much.
Yeah.
Thank you, Mr. Chairman.
Mr. Slaughter.
Thank you, Mr. Chairman. Mr. Leewald, just I notice on page 3 of your testimony, this is the first time that I can recall where the fund payouts have always been larger than the primary care provider or primary insurer's payments. This is the first year that has flipped, which I believe is a direct result of the changes made in Senate Bill 78 that took effect in 2022. I don't want to jump to a conclusion, but I'm assuming this is because most of the funds, when the attachment point was 200,000, the fund picked up the next 800. Is this because most of those claims are now beginning to work their way through the system, and this sort of change will probably be what we'll see going forward? Greater payments at the primary insurer level and the fund stabilizing at a lower amount than in the past?
Yes, I would tend to think so. So we've talked about the 200, 800 versus 500, 500, and that occurred in 2022. And what we're seeing from our caseloads, just generally speaking, those 200 cases are starting to phase out because, with statute of limitations and other issues that can't really be brought up anymore unless you have a case involving a minor. Now, we still do have some cases that have gone through the process for whatever reason. Maybe there's discovery disputes, or, a provider passes away, unfortunately, or plaintiff passes away. So things just kind of get pushed along a little bit further. So we still have some of those, but just to kind of ballpark, I would say 20% of those cases are still the 200, 800 versus 80% for the 500, 500. So that's why we kind of see that flip. And I foresee that probably being the case in the future, but we'll kind of see how things draw out.
Any other questions? Yes, Dr. Gleason.
I just had a question about Missouri. Is the only time Missouri involved when the physician lives in Kansas but practices in both states, like in Kansas City? Is that why the Healthcare Stabilization Fund does anything with Missouri?
Yeah, generally speaking, it's going to be a healthcare provider that lives on the Kansas side. Say they live in Leawood or Prairie Village or something like that, but they actually work over at Research or one of the different places there. So that's almost most of the time kind of what we're seeing for those Missouri cases. Now, sometimes there could be, well, yeah, that's going to be pretty much all I see is Kansas located provider working in Missouri.
Any other questions? Yes.
Part of the motivation from going from the 200,000 to the 500,000 was that maybe some of the carriers weren't motivated to defend their cases and were settling things maybe a little too easy. Are you seeing that change now start where people are maybe defending cases because of the higher primary limits?
Yeah, I would agree with that. I would say they're looking at cases with a lot more what's the term? They're looking in more detail at these cases because, they have a lot more at stake. Basically, if you jump up from 200 to 500, that's quite a bit more. So they're holding on to them longer, which is fine. They're kind of reviewing things and then, they'll evaluate them in more detail. So yes, I would tend to agree with that.
Any other questions?
Nothing further on that part. I have the KU part as well that I just wanted to chat about, if that's okay, Mr. Chair. Okay. So if you move on to the next report, that's going to be, it says at the top, the KU self-insurance programs. So just talk about that briefly. These programs provide the basic professional liability coverage. Now, prior to 2022, much like the regular medical malpractice, it was 200, 800, and then now after 2022, it's 500, 500. By statute, the fund administers these programs and handles claims from first dollar, and then the fund would seek reimbursement for the attorney's fees and expenses, and then for any settlements up to that primary limit. Two separate programs that we talk about here, the KU full-time faculty members and private practice foundations. So this would be your University of Kansas Physicians, Inc. and Wichita Medical Practice. And then the other programs would be the persons engaged in residency training in Kansas City, Wichita, and Salina. These programs don't include KU Medical Center because it's not a healthcare provider and it has coverage from the state of Kansas under the Tort Claims Act. And medical students who are also covered under the Tort Claims Act. And then finally, KU Hospital Authority has primary coverage from a private insurance carrier. So first I'm going to talk about the Foundations and Faculty Program and then the Residence and Training Self-Insurance Program. So just briefly, each year on July 1, KU Hospital has to remit monies so that the fund has a balance of $500,000. This is the private practice reserve fund. Throughout the year, the fund seeks reimbursement from this. Then when the monies are depleted, the reimbursements are to be made from the state general fund. For fiscal year 2025, the cost was a bit over $3.37 million, which is a bit up from last year. In 2025, the Healthcare Stabilization Fund was reimbursed the $500,000 from the Private Practice Reserve Fund, and then it received about $2.87 million from the State General Fund. Why the increase? I would say last year the prediction was that the cost for this year would go up just because we had more claims and an increase in the number of settlements. So this last fiscal year we had 10 claims versus the previous year you're looking at 6. There was a small reduction in the amount of attorney's fees and expenses, but we were still paying a little bit more in claims because you had just what we would call a bigger case, basically, that had maybe a little bit more value that is being worked up. We'll move on to the residence and training portion there. This includes the residents in Kansas City at KU Med Center and then the KU affiliated programs, the Wichita Center for Graduate Medical Education in Wichita and Smoky Hill program in Salina. By statute, all reimbursements for residency programs are from the State General Fund. This previous fiscal year, we had 5 settlements. There were a couple of larger cases. So that's all it takes for these to occur to these to kind of ramp up. If you look at the year prior, it was, I can't remember the exact amount, but it was lower and then it bumped up after that. My prediction for the next fiscal year would be about the same. I think it might be a little bit lower, but the reality is that KU is growing. As you can see, each year they get more faculty and more residents, and they're kind of expanding. So with that, it's just going to come more cases and potentially some bigger cases as well. Going to page 2 of that report, list of expenditures by fiscal year for the past 10 years. Faculty and foundations average the last 10 years was about $2.3 million. Here in fiscal year 2025, it hit $3.3 million. 1.9 of that was in payment of claims, and then the 1.3 of it was in expenses and attorney fees. Which, like I said, would make sense if you have an increased number of claims, they're probably going to have to pay out more. The residence and training, the average over the last 10 years is about $1.1 million. I would say this previous fiscal year was more expensive in that respect, to the tune of $1.75 million in claims payment and $740,000 in expenses. It's quite a jump, but we had more claims, and some of these residents were involved in some of these bigger cases in multiple residents, and they can be expensive to defend. The total number of faculty that have their primary professional liability coverage paid for by the state of Kansas continues to increase. two requirements to be eligible for the self-insurance program for faculty. They have to be a member of a foundation, and they have to have a full-time faculty appointment. Back when it was created, the program in general, it was believed that the intent was for the full-time faculty employed by KU Medical Center who are actually supervising residents. Generally speaking now, of the 1,100 faculty or so, I don't know that they all supervise residents. They have a voluntary faculty appointment. They're not employed by the medical center. They're employed by the foundation and rendering clinical services. Why is this important? All the program costs over $500,000 are going to be reimbursed by the state general fund. So that's going to be paid for by the taxpayers. And then just a reminder that the primary coverage has increased since 2022 to $500,000. So that's all I got for the KU part. I'll take any questions there.
Minnie, do we have any questions? Seeing none? Thank you, Steve.
Thank you.
Appreciate it. Next, we have Clark Schultz, Executive Director. Welcome to the committee.
Thank you, Mr. Chairman, and it's a pleasure to be here today, and thank you, members of the Legislative Oversight Committee. I also wanted to point out that besides we have two Board of Governors on your Legislative Oversight Committee, we have Mr. Larry Vanderweg with us today, who is also on the Board of Governors in the audience, so we appreciate that as well. I will begin with talking about investments and then go on to my report on the investments. And we can go in any direction, of course, that you would like to, although I point out that if I was better at investing, I'd live in a bigger house. But if you'll recall, last year we had, well, just during the legislative session, Representative Helgerson had asked for some information regarding our investments and the policies, the statutes that we're required to follow. And Mr. Scott, Kurt Scott, had provided some ideas regarding commercial investments for insurance companies. So that information was provided to Representative Helgerson and to the revisers so that a bill could be prepared that would give the Board of Governors additional options, possibly without mandating that they do any additional types of investments. The chairman, the director of the Pooled Money Investment Board is brought into that as well, and I will tell you that that's Joel Oliver. He's very good with meeting with the Board of Governors, and the Board of Governors likes to meet with him and receive reports. In fact, he was due to report to the Board of Governors last week, was unable to attend, but will be at the next meeting, where he will do a full investment on the investments that he is able to make on behalf of the Board of Governors for the Stabilization Fund. So the whole idea, of course, is to try to increase the yield, but to do it in a safe manner that is consistent with the mission of the Board of Governors. So anyway, we want to thank Representative Helgerson for his interest, and he may have comments regarding what he would plan to do during the next legislative session. But we do appreciate that. And Mr. Chairman, with your permission, I'll just, you can take questions now on that portion, or I can move on.
Let's talk about investments if anyone has any questions. Representative Helgerson, you want to add some points to this?
If the committee may remember, last year I had several questions and desires to try to open it up for investments. The information I received, let's just say, did not get into a draft legislation that I was comfortable with in the timelines that we have. I'm hopefully going to be available to introduce it into session giving us more of an opportunity, or giving them more of an opportunity to make these decisions. I'll be happy to stand for any questions.
Yes, Representative Carpenter.
So is there a bill draft out there? Are
Yes.
you working with it?
There is a bill draft now.
And do you have an RS number, or is it just
Not with me.
sitting there?
No.
Okay. Well, I think, I kind of lost track and probably just blew it off, quite frankly, last year too. But I think it's imperative when I see these interest rates of 2.5%, and as Mr. Sutter said, he's getting 4% on a CD. I'm not sure, I haven't had time to see how much generation that would be in income, but several $1 million. And I think that that's low-hanging fruit as far as I'm concerned by just introducing a bill to change. Maybe, Jenna, do you have any information on that statute that we're talking about affecting? Did I catch you off guard?
Thank you, Mr. Chair. I was actually talking with Eileen to figure out who drafted this bill, because it isn't one of us. But last year's recommendation was to allow the fund to invest similar to an insurance company, which is in Chapter 40, Article 2A at SEEK. So it's kind of that whole chapter of statutes.
Representative Helgerson, do you have an elevator summary you can give us? That would be good. Seems like it's an annual discussion, so the committee would no doubt be interested. Well, good luck with that. Yes, Mr. George.
Go ahead. You were first.
I just had, so would that be an appropriations bill, or would it come through Health Committee? What do you think? I mean, I'll be happy to introduce that bill and hear it.
The shortness of the session, possibly. I would suggest we go through an exempt committee, and so that,
That makes sense.
you know, and that, so it's available, and if there's not any controversy, and then wouldn't be a problem. But appropriations would be the ideal thing, just as long as we don't get a dissent to appropriations.
Exactly, and so we would introduce it in an exempt committee,
Yeah.
and then I could probably get it referred to Health. I think Health is probably the best avenue for addressing this issue. So, yeah, I'd like to see a bill draft or
Yep.
whatever you've got.
I'll make that available.
And let's get moving on this and get it introduced, and then I'll get it referred to Health, and we'll have a meeting or a hearing and get her done. Send it over to the Senate.
Bipartisan effort. Mr. George.
Yes, thank you, Mr. Chairman. On this, what was the response when you inquired to the MIP investment? Did they have suggestions? Were they open to, because again, I listened to the testimony of our actuarial, which is very important to me, and you do a fine job. When we look at a 10 basis point increase, saves 1.3% decrease. That's substantial to our providers across the state when we look at it. Did the MIP have any suggestions?
Yes, sir, he did. And I think those were passed along as well as far as for the drafting of the bill. Please, and I know you all understand that the way this is set up is to have very safe, very conservative investments that, and for example, there's, I think, 6 investment opportunities, direct obligations that are insured by the United States, corporate bonds that do not exceed 11 years in maturity and are rated in one of the 2 highest credit
rating categories, commercial paper that does not exceed 270 days. And it goes on and on. I do want to point out that if you remove the bonds and treasury notes that we have currently, our last report from pooled money on the other investments is averaged 4.18%. So there, is there room to find, but I think some of these restrictions are perhaps in the way, and I think that's what Representative Helgerson and the board is interested in, Board of Governors is interested in that as well. It's just that it's, and we all understand here, it's with legislation, it can get very complicated and trying to find the right piece, but we appreciate that there was a lot of work done by Representative Helgerson and the revisers last year, which as he pointed out, has put us in a much better position for this next legislative session. So, but yes, he's very involved and is interested in us going in the direction we want to go.
Is there any opposition to expanding the investment list?
I don't believe so. I think that as long as it's one, again, it would give opportunity to the Board of Governors, but not mandate certain investments. I think that would be where some of the opposition would be. Because there's a tendency to be very, very careful. It's a lot of money, and it makes sense to preserve that. So you have that also.
Representative Helgerson.
In my discussions with people, let's go back. We didn't get into this discussion about the rate of return until 2 years ago, is my memory. And we started asking the questions and pushing it a little bit, and last year it became a little bit more of interest. But the committees have not necessarily been prone to change the investment types because of risk that it would put the state general fund. If we have more flexibility to a group of non-elected individuals, quite often, that make policy decisions about how to invest the money, and they mess up, and that it comes back to the legislators, there's been some hesitation among some people about, do we really want to open it up that much? Now, legislators don't have a problem about spending the money for investments they want to make. But there was some pushback when I had conversations with some people. I tried to reassure them that this is very, very safe investments. That's what we're trying to open up to, so that we can get the additional 2 points of investment. But they also look at capers and the minds of legislators on the ups and downs that we've seen in capers in the last few years is still fresh in some of their minds. So even though we immediately say, well, who would be against this? There has been some opposition when I brought it up to legislators and other individuals. So, but I still think it's necessary and it's financially advantageous to the state.
I would agree. A lot of difference between capers investments in here, for sure. Any other questions or thoughts?
I'd just like to comment on the comment. If I heard correctly, you said as we look at the laddering going off and bringing new investments on, did you say we're at about a 4% on some of the new laddering coming on?
The last report with the bonds and treasury excluded, it's 4.18.
Okay.
So yes.
If we look at the fact that we're using some probably more to the 11-year term to look at the rolling of the laddering, we're actually seeing progress under the MIP program to get to 4%. So the question becomes timing on that laddering going off and new money invested in the appropriate. I just like to see people, as a person who wants lower taxes in a county, I like to see people use the funds that we can at the highest level that's safe. Because again, safe is appropriate. And again, I'm like hearing Clark, the 4.1. Thank you.
Any other discussion? Mr. Schultz, go ahead.
Thank you, Mr. Chairman. And again, thank you, all of you, for serving on this committee. The Healthcare Provider Insurance Availability Act was established in 1976, so next year will be the 50th year that we have been in existence. The Act set up three items, or three things. It said that if you are going to be a licensed healthcare provider, as defined in state statute, you have to maintain professional liability insurance coverage. Secondly, the law created a joint underwriting association, which is the Healthcare Provider Insurance Availability Plan, which you've heard a little bit about this morning. And that is to provide liability coverage for healthcare providers who can't purchase the coverage in the commercial insurance market. And this has allowed the commercial market to underwrite to their liking, and if someone is unable to purchase, they are referred to the availability plan. And then the third item is that the Healthcare Stabilization Fund was created to provide excess coverage beyond the first layer of coverage provided either on the commercial market or by the availability plan. So we are there with that second coverage level. There's a paragraph in my report, I won't read it to you, but about the constitutionality was challenged about the Availability Act in 1978, so just a couple of years after it was being formed, and some changes were made, and was declared constitutional. The statutory report is the following items, which are from the fiscal year that ended June 30, 2025. Net premium surcharge collections amounted to $21.464 million. The highest surcharge rate for a healthcare professional was $10,606 for a coverage of $500,000 per claim. A Kansas resident neurosurgeon, also licensed to practice in Missouri, would be subject to the 30% Missouri modification factor, which I think was mentioned earlier to you, resulting in a total premium surcharge of $13,788. The lowest surcharge for a healthcare provider is $200. This is a minimum amount that is used by mostly non-resident providers who are providing minimum healthcare services in Kansas. So it is healthcare providers who are licensed in Kansas who want to maintain that license but aren't necessarily doing much, providing much healthcare in the state of Kansas. Number 4, there were 17 medical professional liability cases involving 21 healthcare providers that went to jury trials, and as you heard earlier, of those 14 cases, or of those, 14 resulted in complete defense verdicts. 1 case resulted in a verdict for the plaintiff, 1 case resulted in a hung jury, and 1 case resulted in a mistrial. And here I would like to compliment our general counsel, Stephen Leewald, which you'll recall the first time that he spoke with you was last year, and he had just taken over from Rita Knoll, who had been with the fund for a long time. She had been over when it was part of the insurance department, and that's some I was going to say big shoes to fill, but Rita wouldn't maybe like that. But anyway, she had done such a great job, and Steve has come in here, and he's scrambled a lot and has been very busy, and we appreciate his work with the Stabilization Fund. Number 5, during the past fiscal year, 556 open claims were closed, which shows you the amount of activity that goes on in a typical year. Of those claims, 5.8% resulted in fund obligations. There were 79 cases involving 95 claims that were settled, resulting in healthcare stabilization fund obligations of $31,668,947. The average stabilization fund compensation per claim was $333,357, and those amounts are in addition to the compensation paid for by the primary insurers, which is typically $500,000 now that we are further along since the new law went into effect a few years ago.
Clark?
Yes.
It's a little bit more on the Kansas resident practicing in Missouri. Do we
Yes.
have to offer that coverage, or why is that set up this way?
Well, if they are licensed in Kansas, yes, because they're able to provide services elsewhere. I don't know if you'd want Steve to come up and address that a little bit more, who probably has more knowledge than I do. But the idea is that the additional surcharge is to pay for the additional costs of somebody that is providing services in Missouri.
So apparently we must feel it's worth it.
I believe that's correct.
Mr. George?
Yes, as a person who's got the experience of working with both states, and I just believe strongly that the healthcare stabilization is helping protect our physicians that live in the state of Kansas, and also the quality of the defense of the stabilization fund with the new 500. And this comes from personal experience for the years I was at Coffee Health System. We want to protect our providers, and we offer an insurance program that helps recruit physicians to our state. And looking at the turnover in some of the places when I look at the state of Missouri and the way they do malpractice over there. So I greatly respect what we've done here as a state, and Kansas should take great pride in the leadership that we did almost 50 years ago.
Good. Thank you. Appreciate it.
Thank you, Mr. Chairman. The balance sheet as of June 30, 2025 indicates assets amounting to $262.7 million and total liabilities amounting to $248.478 million. Next, Mr. Chairman, with your permission, I'll move on to the availability plan, which you have heard about this morning and of course are aware of that sitting on this committee. But the Availability Act that in 1976 created a joint underwriting association called the Healthcare Provider Insurance Availability Plan. The plan assures that healthcare providers have access to basic professional liability insurance, $500,000 per claim currently, subject to $1.5 million annual aggregate coverage. The existence of the plan allows commercial insurers to engage in selective underwriting practices. If an applicant appears to be questionable risk, the insurer can refer the healthcare provider to the availability plan. The availability plan is governed by a board of directors that are appointed by the insurance commissioner, and then the board of directors contracts with a servicing provider. At the most recent meeting of the availability plan, which was October 27, 2025, it was reported that there were 415 plan participants. These are healthcare providers that would not be able to provide health care to their patients in Kansas were it not for the availability plan. Last year, the number was 410, so it's remained about the same. This year, 415 plan participants. If a provider is obtaining their liability coverage from the availability plan, they will also pay an additional surcharge. It's a little bit higher. So they will pay about 33% more premium for basic coverage than they would if they were insured by a commercial insurance company. They also pay the higher surcharge rate. So
all in all, they pay a provider that is obtaining availability plan coverage is going to pay about 36% more than their peers do in who are providing or buying on the open market. You heard from Russ talking about the fact that the availability plan, we act as their reinsurer, basically. And so on the years where they have done well, they would send any additional premium money to us and vice versa. Last year, as we stood here, as you recall, we had transferred $3.871 million, or were required to send that to the availability plan. This year, it's $602,574 that we have already transferred to the availability plan. We've talked about recent legislation, effective January 1st, 2022. The basic coverage level that provider must obtain from an insurer increased from $200,000 to $500,000. And we have been filtering through the $200,000 lawsuits and claims, and we are getting more and more of the $500,000, which that's what is supposed to work, and it is leveling off. Each year, as also has been referred, the Board of Governors sets surcharge rates. There are 24 different classification groups, and they use the information that comes from the actuary to try to come up with surcharge rates that are fair and adequate. And I will, as Mr. Slaughter pointed out, the improvements that have been made, particularly on the hospital group, the board has taken that job very seriously, and it is smoothing out very nicely. They take the actuary information, they use that, they do it exactly what they're supposed to according to Kansas statutes, and I want to thank them for that. It's a process every year that they go through, and then they set the rates for the next year. So the rates are now set that will go into effect on January 1st in about a month and a half from now. There is a section called Historical Overview. I'm not going to spend a lot of time on that. But it is something that if you would like to read, it talks about the legislation and so forth, and the way that the industry has changed in the last 50 years as well. So with that, I will move on to just conclusion. Yes, sir.
I might have a question if you could cover for me.
Okay.
We're talking about investments and concerns from legislators that somehow the taxpayer may end up owing the bill because corporate bonds or something may not pay. How is this set up? When does the taxpayer actually ever owe money on this? If we blew through the $270 million, or how does the taxpayer ever get on the hook?
Well, in theory, good question. In theory, that would never happen, but there would be an obligation. I mean, if disaster hit, there would be an obligation by the state to make good, is my understanding. This is all spelled out in the statute. There was a time in the past, in the recent past, where the legislature was looking for sources of money, and they kind of took some money from the stabilization fund, and I think that has all been paid back. But generally, it would have to be something like, if Capers is huge, of course, but if in theory, if Capers had huge problems, somebody would make up the difference, the taxpayers. So that should not happen, but I guess it could.
Just curious about that. Any other questions before we go into the conclusion? Yeah. Mr. Slaughter.
Thank you. I'm not aware that the state of Kansas would have any obligation to cover deficiencies in the fund, except to the extent that they insure KU faculty, residents, and that group. But that's the only place where the state of Kansas participates in providing revenue to the fund. If the fund should become insolvent or they mismanage their assets, the fund would begin to recoup that money from the provider community who are required by law to pay a surcharge into the fund. So I don't know that the taxpayers would have any obligation to cover any shortfall that the fund would have. I'm not aware of that. Perhaps there's some provision that I've missed, but I think this is by and large, and since its inception nearly 50 years ago, been supported and maintained by the premiums, if you will, that are paid by actively practicing healthcare providers. Not the same.
Sense to me, I appreciate that. I was just thinking about the pushback from a few legislators. Maybe we need to make that clear. So, very well, thank you.
Yeah, thank you, Mr. Slaughter, and that was a good answer. I think the answer to that, though, is to some of the pushback, is that would be a fear that, well, if something was mismanaged and there was a loss in income and they weren't able to do this, are we going to just let them? You know, what would happen? And in some other states, the legislature has gotten involved in trying to make whole. So what would happen? And again, as I said, in theory, it should never happen. So I didn't want to imply in any way that there was some cut and dried statute that tells exactly what happens if the stabilization fund had financial problems.
Thank you.
In conclusion, the Availability Act is a successful public-private partnership, creates a favorable environment for responsible professional liability insurance companies, and we believe that since 1976, the Availability Act has accomplished its legislative intent. It's assured Kansans a reliable source of recovery when it's determined that compensation should be paid for an unintended medical outcome. And it has assured Kansas healthcare providers that they will always have access to adequate professional liability insurance coverage. I will close with, we get anecdotal comments from the healthcare providers across the state, and I think it's largely, from what we hear, they're very satisfied and are glad that the Stabilization Fund exists and have been very happy with what it does in helping them with their practice. So we appreciate their comments, and we hear that quite regularly. With that, Mr. Chairman, I would stand for any more questions.
Last chance here. Any other questions, thoughts? Thank you, Mr. Schultz. Appreciate it.
Thank you, Mr. Chairman.
Our next conferee is Kurt Scott, CEO of CAMCO. Welcome to the committee.
Okay. I'm going to make sure I'm on. Okay, there we are. Thank you, Mr. Chairman. My name is Kurt Scott. I am the President and CEO of Kansas Medical Mutual Insurance Company, CAMCO, as it's known by. I appreciate the opportunity every year to appear before the committee and provide a report, both as it relates to the activities of the plan, which we've heard a lot about this morning. I'll try not to duplicate some of what you've already heard as much as possible, but also then give you a feel for what's going on in the medical malpractice insurance marketplace, because that has a direct impact on, in the environment here in Kansas, but it also becomes a reflection of what the industry sees in terms of the environment in the state of Kansas and nationally. So we have been the servicing carrier, CAMCO has been the servicing carrier for the plan since July 1st of 1990, so quite a few years. We've seen a lot of ups and downs in terms of the financial results for that plan over the years, and the number of providers and the types of providers that end up in that plan. As Clark mentioned, there are currently 415 healthcare providers that are in that plan. 230 of them are physicians, about 40 other types of providers that could include CRNAs, physicians assistants, other defined healthcare providers that are also, for whatever reason, in the plan. There are 40 moonlighters. So if you are if you're a residency and residency training here in the state of Kansas, and you want to go outside of that residency program and, let's say, cover an emergency room on the weekends out in western Kansas, or other sorts of other extra, well, I hate to say extracurricular, but outside of the residency program, you have to then obtain malpractice insurance for that purpose. And the only source of that, because it's done in a really unique way to dovetail into that residency program insurance that you've heard a little bit about already this morning as well, the plan does that. And there are 40 of those residents that are in residency training that are out moonlighting on a somewhat regular basis outside of that residency program. And they're in the plan. And then we have 60 adult care facilities, long-term care facilities that are in the plan. As you'll recall, January 1st of 2015, long-term care facilities, along with nurse midwives and physicians assistants, became defined healthcare providers, became in the fund, had to be compliant with the fund by malpractice, just like physicians and hospitals do. And at that time, we had very few in the way of adult care facilities in the plan, but that has grown over the last few years, and I'll cover that in just a second. What I may do is point you to a graph that's on the back page of my written testimony. It's the last page. And the top part of the graph is like the last 10 or so years of insureds in the plan. And you'll see, starting in 2010, that number came down. It was at 430. It came down to a low of 277, and then it started climbing again in 2021. That is, and if you look over time, that's what's happened. And if you follow that trend over time, it's a direct result of what we in the industry would call a soft market cycle or a hard market cycle. Soft market cycle meaning readily available, usually relatively inexpensive malpractice insurance, relatively. A hard market cycle would be when the industry pulls back a little bit for some reason. It might be in a particular line of coverage, a type of provider, or it might be, as it was back in the 1970s and the late 1980s, a complete pullback where literally companies would leave the state and not offer that coverage any longer. Part of the reason CAMCO was formed in 1989 was that exact issue happened in the mid to late 1980s. Medical society stepped up and said, we've got to take control of our own destiny, form our own company, and take responsibility for that part of the healthcare environment. And so you can see in the last 4, 5, 6 years, that cycle is what we would call sort of a hardening cycle. It's not a hard market. Coverage is still available. Prices are going up, reflective of claim costs, but it also is reflective, I think, of the unwillingness of the industry to insure certain risks who are generating claims. And so they're backing away from some of those. And again, 60 long-term care facilities, there are about, I want to say 350 or so of those in the entire state. 60 of them are generating a frequency of claims that's unacceptable to the regular market, and they've ended up in the plan. And that, I'll continue that story in just a minute. But that is because the plan is the insurer of last resort. If you're entitled to a license to practice, whether it's from KDHE or Board of Healing Arts to practice healthcare in this state, you're entitled to malpractice insurance if you're a defined healthcare provider. And if you can't find it anywhere else, the only place you get to go is the plan. So the plan doesn't get to select the risks. It just has to take whatever's left that the rest of the industry won't take. Move on. So in terms of a sense of what's happening as it relates to the financial results of the plan the last few years, as Russ and Clark pointed out, most of that story has to do, almost all of that story has to do with an increased number of long-term care facilities that ended up in the plan. That was sort of an outgrowth of what happened during and as a result of the COVID-19 pandemic. They weren't COVID claims, but these are facilities that then began having a higher frequency of claims. Industry pulled away from those homes, and they ended up in the plan. We had, to give you an idea, in 2018 and 19, we had one long-term care claim per year, so one in each of those years. By 2020, that jumped to 11 claims. In 2023, it doubled again to 19, almost doubled again to 19 claims. Out of a total claim for all of the plan population of about 24 claims. So 19 out of 24 were long-term care home claims. That led to financial losses for the plan, which has been documented. So far, we're seeing a return back to normal frequency levels. I would say as of right now, we've got a roughly 15 total claims in the plan for the calendar year 2025. 10 of those are long-term care claims. So we're starting to come back down. It won't go down to 1 or 2 like we had a few years ago, but it'll come back down to more normalized levels. An interesting side note, and I noticed it when Russ did his presentation, if you look at his table that dealt with those providers who are paying too much, those providers that are paying kind of just right, and those providers who are not paying enough, his 3 different categories, 3 different columns. The fund surcharge for adult care facilities, for long-term care facilities, is in that left column. So this isn't a severity issue or the size of the claims. This is a frequency issue or the number of claims. Those are all ending up mostly in the plan, and they're being dealt with inside of the plan's policy limit, not so much in the fund. So it's just kind of another sort of side note, unique circumstance that sort of occurs from time to time in our industry. Are there any questions about that? Because that's what's driving the losses in the plan is, and keep in mind, those losses they're accrued losses. They haven't all been paid yet. So we don't know what the final answer is going to be on that for probably another 2 or 3 years. But we have our own actuaries who make us set up reserves and anticipate what may happen. And so that's a result of that frequency of claims that are being seen for long-term care claims in the plan. Okay.
I have a question. Representative Carpenter?
Thank you, Mr. Chair. So obviously, I think it's obvious that this was from COVID.
You know, so Representative Carpenter, I would say the thing that happened during COVID, all healthcare providers are put under stress. Adult care facilities, particularly so, as we all know. They struggle from a financial standpoint, they struggle from a staffing standpoint, and management, staffing, financial conditions, as you might imagine, for any business, creates potential for risk. And that's what's happened in the adult care field nationally. It isn't a direct result of COVID-type claims, it's a result of the COVID environment. That makes sense?
So with that, what would you see we were timing out of that? Is it 5 years?
I would say we're starting to see that begin to happen now. So yes, I would say in the course of the next couple of years, we'll sort of normalize I think staffing issues have always been a problem in the adult care facility environment. And so, but hopefully it'll reset back down to what we view as a more normalized trend.
Very good. Thank you. Thank you for that. Thank you, Mr. Chairman.
It seems like in the last couple of years, we talked a little bit about perhaps could the legislature step in and help a little bit with the long-term care exposure. Did anything ever come of that?
I'm not aware anyone aware of that. I'm not aware of that. But I think that, I mean, all of healthcare is struggling right now as it relates to delivering more care to more individuals with less money. And so everybody's got the same problem. I would say that it probably is even more acute in the adult care world. And as we all age, end up in those facilities, it's the baby boomer generation moving through, from a demographic standpoint, that's going to further exacerbate that problem. As it relates to the overall medical malpractice insurance marketplace, I would say that we have, and I've mentioned this in previous interactions with this committee, that there are a number of headwinds for the healthcare provider community, which then ends up being headwinds for the medical malpractice industry who serves that community. One of the things that we are seeing, and it's in all of the industry publications, every meeting I go to, any industry meeting is talking about the increased frequency of high severity claims, so meaning much bigger claims. And you probably read about them. And in fact, one of them was in New Mexico, was a $440 million verdict in New Mexico. I think it was recently reduced down to only $200 million. So, but you can imagine claims of a variety of 40, 50, $80 million. Georgia has a number of them. $400 million in New York, $400 million in New Mexico creates a lot of attention from the medical malpractice industry, and that is a trend right now. Fortunately, in Kansas, we haven't seen that same degree of verdict or settlement in medical malpractice cases in Kansas. But we do have actually, and as we mentioned in the last couple of years, the Hilburn decision created some uncertainty about our cap on non-economic damages, whether or not that applies to medical malpractice or not. Obviously, we've talked in the past about waiting, for a case to come through to get to the Supreme Court to sort of clarify some of those issues because they were made unclear in the Hilburn decision. Well, we finally got our wish. I hate to celebrate this, but there was, not a Camco case, but there is a case that was mentioned. I think Stephen mentioned it during his testimony. $5.7 or $5.8 million verdict in Johnson County, and it's got a lot of unique characteristics to it. And rather than me do a terrible job describing it and the different legal ramifications of that, at the end of my testimony, I'm going to have Tucker Poling, who is our Vice President of Claims and General Counsel at Camco, who is well-versed in what's going on with this case and some of the issues involved. I'm going to have him talk briefly and answer any questions you might have. This may be one of those cases that works its way up to the Supreme Court and gives the court an opportunity to provide some clarity as it relates to a variety of issues, and I'll let Tucker talk about that at the when he gets a chance. The other issue that we have talked about last year especially, and has been a topic for discussion, actually was mentioned, I think Jenna maybe mentioned it in her review, is the expanded scope of practice for, in this case, APRNs, and the requirement or the requirement that they have malpractice insurance, but there was no requirement that that malpractice insurance be part of this mechanism of the Healthcare Stabilization Fund. There are, we've studied, there's been some national studies. This is not a Kansas phenomenon. This is going on around the country, nationwide, expanded scope of practice where these providers are providing more direct care that is not necessarily at the direct delegation of a physician, which then, as you might imagine, creates risk, and as you might imagine, creates the same sort of risk environment for those providers as do physicians. The CAMCO study that we did a few years ago looked at about 10 or 12 years worth of data, and what we discovered is going all the way back to maybe 2010, very little in the way of frequency of claims for APRNs. And that has grown, and to be, and same thing in terms of the severity of those claims. That's grown to be pretty much on par with what we see for physicians. So the frequency and severity of claims for APRNs, at least in our population, is representative of pretty much the same sort of experience you would see for physician claims. And since many of them are providing the same sorts of care, it's not really a surprise that that's the case. I'm going to go back to something that somebody asked a question about the Missouri providers, or excuse me, Kansas providers being sued and having cases in Missouri. Healthcare the Healthcare Provider Insurance Availability Act put in place almost 50 years ago. Mr. Slaughter will remember it just like yesterday because he was there. It was really, the premise of it was to protect Kansas patients and Kansas providers. So if you are a Kansas resident provider providing care in Kansas or elsewhere, the fund's going to protect you. That's the whole idea. Provide you with insurance, readily available, affordable insurance to cover you wherever you're practicing. If you're a Kansas resident provider, if you're a Kansas patient, it's going to protect you. I mean, that's the whole goal of the Healthcare Stabilization Fund, is to protect the patients and the providers and create a reasonable environment for the delivery of care in the state of Kansas. Whole reason for its existence. And so as we look at the APRNs, they're not benefiting from that same level of protection. There are things built into the Healthcare Provider Insurance Availability Act that provide protections like no vicarious liability, so no sharing of liability between two different defined healthcare providers. That is an issue that is resident in this case, and we have Tucker talk about one of the many issues. So that's something that I think needs, again, somehow to be discussed. I know there was a bill introduced last session in the legislature, and it is, in terms of the protection of patients and the providers that are delivering the care, in this case APRNs, I think it's something that from a policy standpoint should be looked at by the legislature. So as it relates to, we've talked a lot about the change in policy limits.
We have a question here.
Yes, I'm sorry.
Representative Carpenter.
Thank you, Mr. Chair. So elaborate on the APRN deal. So I'm looking through this. They're getting their insurance privately then?
From somewhere, yeah.
From somewhere?
From somewhere, okay. Yes. So, but they are not participating in the Healthcare Stabilization Fund.
Right.
Not able to.
So if they're able to get that privately, then they shouldn't have a detrimental effect on the Healthcare Stabilization Fund. Would that be a correct assumption?
Well, they wouldn't have a detrimental effect on the Healthcare Stabilization Fund, but because the fund goes through a process of collecting an adequate surcharge from whatever provider is providing the care to match up with its claims experience, in theory, there should be no detrimental effect to the Healthcare Stabilization Fund, even if they were in the fund. The detriment that's occurring is that the APRNs who are maybe working for other individuals, they have their own entities, those things do not get the same benefits from being in the fund. Statutory benefits in terms of, and it turns the temperature down on the liability that they otherwise would, that they would be at risk for. if they were in the fund.
And thank you for that. So what would the people that are against that, what would their arguments be for the APRNs being as part of the Healthcare Stabilization Fund? What would they?
So I think that it got wrapped, the debate about scope of practice and the expanded scope got wrapped into this, well, then you should be in the fund. And so I don't know that I can untangle all of that. But what I would say is the APRNs that I've had discussions with about this issue is a lack of understanding of the construct and the structure of the Healthcare Stabilization Fund and the protections that it provides. And when I talk about vicarious liability, everybody's eyes glazes over, just like yours are right now. But the issue is if Dr. Gleason over here is delivering care in Darrell Conrady's hospital, both of them are defined healthcare providers. And so Hospital Darrell is only responsible for what Hospital Darrell did or didn't do. And Dr. Gleason is only responsible for what Dr. Gleason did or didn't do. They're not vicariously responsible for each other. If you add an APRN into the mix, all of a sudden, and he or she is employed by Hospital Darrell, he's responsible for what he did or didn't do, and he's now responsible for what APRN Jones did or didn't do. And you'll hear a little bit more, and what that does is that gives an avenue to get into the bigger pockets, the bigger tower of insurance. Same medical risk has occurred, but the settlement value of that case shot up dramatically and creates additional risk for the hospital, additional risk for Dr. Gleason in this example, and additional cost. Whereas if they were all held responsible for their own liability and protected by the fund, that sort of calms down that risk from a liability and severity standpoint. That's why everybody's eyes glaze over, because it's sort of in the weeds, but that's why the system in Kansas is so much better than what we see in Missouri. It's why they pay 30% more if they go practice in Missouri than if they practice in Kansas, stuff like that.
So in a nutshell, you would be an advocate for putting the APRNs in the Healthcare Stabilization?
I think they should. I think if they understood it, they would want to be in the fund. That's what I think.
Very good. Thank you for that.
Mm-hmm.
Mr. Slaughter?
Thank you, Mr. Chairman. To this point, or this point that's just being discussed, it should be noted that there are currently quite a few APRNs in the Healthcare Stabilization Fund. Nurse anesthetists, there are over 1,000 of them in the state. Nurse midwives, there are like 40 or 50 in the state. So of the 4 categories of APRNs, 2 comprising over 1,000 are in. There's a larger group of APRNs that are not nurse anesthetists or nurse midwives that are not in the fund, although they were given the ability in, I think it was 2022, to prescribe drugs without a physician involvement or a physician protocol. And when you start doing that, it creates risk because they're doing things now that sort of generate risk and losses. And honestly, I've never understood why we would include one group of APRNs or 2 groups of APRNs, but not the largest group. And I think that's the issue before the legislature. The legislature did not address it at the time when they passed the bill in 2022, I believe it was. And as Mr. Scott has said, I think it weakens the construct of the Healthcare Stabilization Fund from a public policy standpoint. It's a little hard to explain why one group would be included and a similarly licensed group would not be included.
So as it stands now, with them not in the stabilization fund, if they get sued and they lose $1 million claim, the main insurance company pays $500,000, and who pays the other insurers have to pay the whole million because you don't have the?
So as of right now, the APRNs that are not in the fund are mandated by a very generalized line in their, that statute that Dr. Slaughter, that Mr. Slaughter just mentioned. I doctor everybody. Dr. Slaughter just mentioned, says they must maintain malpractice insurance. Doesn't say how much, doesn't say from where. It also does not put them in the fund. So they may have $200,000 worth of coverage. They may have $1 million worth of coverage. There's no statutory requirement of the amount of insurance or where they're getting it from. So there are authorized insurance companies licensed in the state of Kansas. They may be headquartered elsewhere, but they're licensed here, governed by the state insurance commissioner. If for some reason they're unable to pay the claim, there's a guarantee association, there's a construct to provide all that sort of protection. But there are also risk retention groups, and there are excess and surplus lines carriers who provide all sorts of different coverage. So it could end up, and actually, I ought to have Mr. Conrady answer this question. He'd be better at it than me. But there's nothing statutorily that says where they get that coverage or how much they have to have. So the $1 million claim would get paid by their company, the insurance company they bought it from, if they have $1 million policy. If they have a $200,000 or a $500,000 policy, then they would be subject to the limit of that policy. And the provider, or perhaps the provider's employer, is going to end up with the responsibility for anything else because of that vicarious liability issue. And again, we get deep in the weeds when this happens. And Mr. Conrady, if I murdered that, please let me know. So.
And a person who has actually employed ARMPs over the years, the risk is really to our community and the patients in our community. Because I could have an arrangement with an ARMP that I pay up the malpractice. However, I have to be specific. If that he or she that wants to practice somewhere else, they have to have a separate policy. So when we look at this, this is like when you look at other states and slotting of job functions, you as the primary employer of 3 to 4 days a week of an ARMP then is at risk to make sure that ARMP could go a little unique and want to work a fill-in with another company, and that clouds things. And most people in Kansas believes when you go to any of our large institutions and they're utilizing ARMPs as a physician extender, that those people are covered so you're protected. It's a unique situation. I think it's important to look at how that flows because, again, as a former CEO, I am worried that we're leaving people with the expectation that that person, because they do have coverage, doesn't necessarily have that coverage when they're working with Dr. Conrady or Dr. Slaughter at their organizations. And it just worries me that we're not providing that coverage that we should.
So one thing I will say, CAMCO already we insure APRNs. We do it in one of two ways. We either to the hospital or maybe a large physician clinic, we issue what's called an additional insured endorsement that covers all of their non-defined healthcare providers, in this case APRNs. There's $1 million limit that covers all of that. But it only covers those non-defined healthcare providers for what they do at Conrady Hospital. So if they go over here to this hospital or to the Slaughter Clinic, that policy that's been issued there doesn't follow them. We also issue individual policies. Same thing though, there's an endorsement in there that basically says it's where you're for this place and this place only. I've run into a number of hospital administrators because they're used to the way that the Kansas construct works with the fund and everything. One policy follows you everywhere you go. That's all I got to worry about. I get proof of insurance and I'm done. And that is not true in the case of APRNs. They might get a policy, they think they're done and it's covered, but they don't get a copy of the policy. They just get a copy of the proof of insurance. And a certificate of insurance. It doesn't get into all the details of all the coverages and everything. And Mr. George is exactly right. we run the risk of leaving a patient without coverage. We run the risk of leaving an APRN without coverage. The whole purpose of the Healthcare Stabilization Fund was to cover Kansas patients and Kansas providers. And this is becoming a growing gap in that because the APRNs with an expanded scope of practice providing more care, they should be, we need them to be, but they're not insured, they're not getting the benefit of the same construct that we've provided to everyone else.
Good information.
The only other thing, I've probably taken up more time than I should have, but I would just say the Senate Bill 78 going from 200 to 500 in basic coverage, and of course the changes that happen then with the Healthcare Stabilization Fund that follow that seems to be working relatively well. It's doing what we expected it to do, puts more responsibility on the shoulders of the insurance industry to manage those claims, manage them effectively, and that is happening. I think Stephen made the comment earlier that he's seeing that is occurring. That was one of the main reasons for Senate Bill 78. I think it's working. You know, obviously there's a few, as we go along, adjustments that everybody has to make, but overall that seems to be working pretty well. And I think if I can, unless there's any other questions, I'll have Tucker come up and talk about the Yates case.
Yes, we have a question.
Yes.
Dr. Kincannon.
Thank you, Chairman. We talked primarily about APRNs being employed somewhere and working elsewhere. There are also groups of APRNs that are independent, not affiliated with a hospital, and the protection for the patients in that is limited too. So, you know, and a lot of those APRNs are out in rural parts of the state. So again, back to the point that it really benefits them to be part of this system, and it also benefits the patients that they're serving.
Yes, great point, Dr. Kincannon.
Tucker, welcome to the committee.
Members of the committee, Tucker Poling, I'm General Counsel and Vice President for Claims at CAMCO. We wanted to just put the case that Kurt referenced on your radar screen because it highlights three issues. One, the general cap on non-economic damages in Kansas. Two, the wrongful death cap in Kansas. And then the vicarious liability issues that you all have been discussing. So just to give it some context, without hopefully putting people to sleep, there's two primary non-economic damages caps in Kansas. One is 6019 A02. That's the general non-economic damages cap that applies to all personal injury cases. That's the cap that was undermined by the Hilburn decision. So that was a trucking accident case. That was there was no majority opinion issued in that case, so there's some doubts about the precedential value of that case, but that did undermine the general non-economic damages cap in Kansas for personal injury actions. Okay, so that's for personal injury actions, non-economic damages. The other cap is a wrongful death cap. That only applies to wrongful death actions that's brought by the heirs of the person that died. That's a statutory action. So the Hilburn analysis that the court went into about, you know, the common law causes of actions being incorporated into the right to trial by jury doesn't really apply well for a statutory cause of action. So that's the wrongful death damages cap falls under that category of a statutory cause of action cap. In this case, in most cases, typically when you have a wrongful death case, you're going to have two causes of action. You're going to have the wrongful death cause of action that's brought by the heirs, and then what's called a survival action that's brought by the estate of the deceased person, which is for the pain and suffering that is suffered between the alleged negligent acts and the death. So both of those caps are implicated in a typical wrongful death case. And that's what was the case in the case that Kurt was referring to, $5.7 million verdict in Johnson County in the Yates v. Advent Health case. That was a case in which A patient came into an emergency room accompanied by the patient's husband. Patient's husband reported concerns about suicide risk related to his wife. They were seen by an APRN who was staffing the emergency department, who was employed by an emergency services company, not by the hospital, and that's important. Long story short, that patient was worked up, was also seen by a licensed counselor there at the hospital. The patient was discharged, and unfortunately, 3 days later, the patient committed suicide. Then we have a wrongful death case and a survival action that's brought by the estate and the heirs of that patient. That resulted in that $5.7 million verdict. And in that case, both the non-economic damages in the wrongful death cause of action exceeded that cap for wrongful death. And in the survival action, the non-economic damages exceeded the cap. Now, the court did apply, after the verdict, the court did apply the wrongful death cap to reduce the non-economic damages in that action down to the cap, but did not apply the general personal injury cap to the survival action. So both sides, plaintiff's side and the defense side, have an appeal issue there that could potentially bring those issues back up to the appellate courts in Kansas. So it's significant to be on your radar screen that we could get some clarity on those issues, potentially. Who knows? That case, I think, is still in post-trial motions. I don't know what's going to happen, but I know that both sides have objected to the rulings on the cap applications in both ways. But the other issue that's raised by that case is that the hospital, Advent Health, was held vicariously liable for the APRN, even though the APRN was not an employee of the hospital. Because under agency law, you can still be held vicariously liable even if you are not an employee. And to the point that was discussed earlier, if APRNs were within the fund, the hospital would have been protected from that claim. So that claim just wouldn't have been available in that case. So that's just a practical application of how this works in the real world. You have someone, you have a claim that's made against someone who's staffing an emergency room. That creates additional exposure for the hospitals for when that person is not covered by the fund. So that's the long and short of it. It's kind of hard to summarize orally. It's easier to do in written format, but I've done my best. Any questions on those issues?
Any questions? Mr. Slaughter.
Thank you, Mr. Chairman. Tucker, do you have any idea how long it will take to resolve this? I mean, realistically, if it works its way up to the appellate courts?
Right, and just to clarify, I think Kurt mentioned that this is not a CAMCO case. This is not a plan case. You know, we administer the plan's claims too. So, you know, I'm not involved in this case. Neither the plan or CAMCO is involved in this case. That said, they are currently in post-trial motions, so I think last time I looked at the docket online, they've got a hearing scheduled for December to potentially rule on those, and then they'll have 30 days. Both sides will have 30 days after the final judgment is entered to appeal. So we probably won't know until mid-January if that case is going to be appealed. But both sides have at least teed that up in terms of their motion practice in the trial court. They've teed up those issues dealing with the constitutionality of the wrongful death cap and whether Hilburn should apply in this case in terms of the personal injury non-economic damages cap.
Mr. George?
One follow-up question. When you're talking about the issue of the hospital employing an outside agency and being vicariously liable, were they billing for that company, or was that a separation of adjudication of a claim?
I don't know whether they were billing for that company. You mean whether the hospital internally was billing?
Or the ER services of the professional?
I don't know that. Yeah, again, this was not a CAMCO case, but we do follow all these cases, so I don't know that. I'm sorry.
I just know there's a lot of hospitals, they'll hire agencies to run the ER, but then bill on behalf of those providers. Right. I'm just looking at it in the future of where is the liability there. Because again, you're representing yourself as one going through credentialing, going through medical staff bylaws.
Right.
You're authorizing that person to work, so I think it gets very complicated.
Yeah, it's a fair statement.
Dr. Gleason.
What are the caps?
Okay, so the caps, the 6019A O2 cap, the general personal injury non-economic damages cap is right now $350,000. The wrongful death non-economic damages cap is $250,000.
Any other questions?
While I'm here, with the indulgence of the chair, I just want to join Clark's comments about the job that Steve Lewald is doing in terms of managing claims at the fund, and the fund in general is well run. And I can tell you just from, knowing peers in other states' experience, that's not always the case, that you have a really well-run fund like we do here in Kansas, and it makes a big difference in terms of how claims are handled and whether they're handled reasonably and objectively. And I can tell you, as someone who's deals with the fund a lot on the claims side, they're doing a good job. Thank you.
Thank you. Next we have Ms. Rochelle Colombo. Welcome to the committee.
Good morning, Mr. Chairman, members of the committee. I'm Rochelle Colombo. I'm the Executive Director of the Kansas Medical Society, and I'm here on behalf of our physician members as well as on behalf of the Kansas Hospital Association. They were not able to attend today, but will join us in our remarks. I'm going to testify today very simply on the question that the statute requires of you, the question of should the Oversight Committee continue and is it actuarially sound? And it is our belief that the Oversight Committee should continue. And I think today's meeting has been just a wonderful example of the importance of this Oversight Committee and the work that it does to maintain this very, very successful public-private partnership. It says in my testimony, 40 years old, but we're on the cusp of 50 years of the success of the Healthcare Stabilization Fund. And it has required a lot of oversight and adjustment for all of the reasons that you all have heard about today, the rates that are intended to be equitable across the provider types. And though we've spent a lot of time talking about physicians and hospitals and some of the providers that aren't included, I think it bears noting that there are several defined healthcare providers that participate in the fund. And when this was established, what was looked at is some of the discussion that we've had earlier today. Who needs to be in the fund to make sure that patients are protected? Who's on the first line of delivering care that could potentially relate or result in harm? Because if it's going to protect providers by allowing them to have insurance coverage and therefore provide access, it also has to cover patients who could encounter harm. And so we do believe that the discussion that you all have had today is incredibly relevant. It has always been our position that as the legislature considers scope of practice issues that would allow different provider types to do things that constitute medical care and could create risk, that those groups should be included in the Healthcare Stabilization Fund. And that is for the protection of patients so that they do have an adequate right to recovery. I think it was demonstrated today in the conversation around APRNs who are required as a condition of their Practice Act to carry malpractice coverage, but it's not stipulated to what extent. And there are protections within the fund that protect those providers and the other providers that are a part of the delivery care team. And so we really don't, it's not about one group of providers. This isn't just about physicians or hospitals or even just APRNs. It's really about anyone who's going to be holding themselves out to provide care for patients that could result in harm. And so we would encourage this body to consider recommending to the legislature that as they look at changes related to licensure and scope of practice, that they encourage that to include participation in the Healthcare Stabilization Fund. There are several things that come before the legislature each year. They don't all change in ways that are substantial in terms of creating harm. But if they're doing medical procedures, surgical procedures, prescribing, anything that overlaps into the practice of medicine, we do believe they ought to be included in the Healthcare Stabilization Fund. Ultimately, that is, the only other thing I would add, I don't think it was mentioned earlier, that for defined healthcare providers, we use that term a lot, both in this meeting and then broadly in the legislature, and there's a couple of different definitions, and so it gets confusing. But as it relates to the Healthcare Stabilization Fund, a defined healthcare provider is one who is included in the fund, and that means that as a condition of licensure, they must, so in order to practice in their field in Kansas, they must purchase primary insurance on the private market and then participate in the fund. And as a result of that, patients know that they have $1 million of coverage, they have a right to recovery, and then they get those protections in the fund, most notably vicarious liability and hopefully, and we'll see, as both Tucker and others have mentioned, the protection of the cap on non-economic damages, which has been something that's been upheld in the past because of the existence and the wide participation in the Healthcare Stabilization Fund. That is of utmost importance to Kansas patients and to continued access. You heard Mr. Scott talk about the transition that we're moving into a harder market where we're seeing really massive excess verdicts in other states. You've also heard Mr. Sutter reference that there used to be healthcare stabilizations in multiple states. There are some that still have them, but in New Mexico, their fund has not been solvent, and taxpayers had to foot some of that bill, and they saw those increases and still had a deficit. That has not been the case in Kansas. It has been very, very well managed by our actuaries and by our Board of Governors, who are doing the right thing to make sure that this serves its purpose, which is to actually stabilize the malpractice market, which ultimately results in more access for Kansas patients. And so we would encourage you to support the continuation of this committee. We do believe it is actuarially sound, and I'd be happy to stand for questions.
Do we have any questions?
Thank you.
Committee, you'll also see we have written testimony from Doug Smith, Executive Director of the Kansas Academy of Physician Associates, and a written testimony from Jill Denton, Executive Director of the Kansas Trials Association. Thank you to the conferees today. We're now at the point where we can take a look at proposed amendments to the Healthcare Provider Insurance Availability Act. Do we have any motions that the committee would like to make other than the two we need to make? Yes, Representative Carpenter.
Well, I think that we should recommend that APRNs become part of the Healthcare Stabilization Fund.
We can have a discussion on that. Is there a second? We have a second from Representative Helgerson. A discussion. Yes, Dr. Gleason.
Do you think it also needs to include what they have, maybe a question for Kurt. If they are part of the Healthcare Stabilization Fund, do they automatically have to have coverage of $500,000? Okay, that's what it was, okay. Second.
Any other questions or discussion? Very well. All in favor say aye. Aye. Opposed, nay. Ayes appear to have it. Any other motions? Yes, Representative Helgerson.
Well, I will make a motion that the committee endorse the idea of providing legislation that enables the committee to use a variety of different financial investment procedures. Yeah.
We have a second from Mr. Slaughter. Discussion.
I think we made that motion last year, but I think it would be good to have it again this year.
Motion and a second. Yes, Mr. George.
I just want to compliment with Mr. Schultz that I was hearing in the report that the MIP actually has new dollars coming in for your investments at over 4%. So again, I think sometimes it's just the timing as well, but thank you for sharing that good information on that.
Good. Any other thoughts, questions? All in favor say aye. Aye. Opposed, nay. The ayes have it. Any other motions? Yes. Slaughter, Mr.
Oh, I'm sorry, Mr. Chairman. I assume it'd be the two motions we normally make at this time each year. I would just renew those again for the forthcoming year about continuation of this oversight committee, its value, and yes, and no need to appoint another actuary. Mr. Sutter continues to do a good job and has the confidence of the Board of Governors as well.
Second? Very well. Wayne, anything we need to do with that? Pretty straightforward.
Mr. Chairman, I just want to compliment our actuary on his transparency, his honesty, and the fact that he has always encouraged people to look at the whole and looking how we can do things better. And he's been a great asset to the Board of Governors.
Good, appreciate that. Any other comments? All in favor, say aye. Aye. Opposed, nay. The ayes have it on both amendments. Any other discussion? Any new business? Very well. Appreciate all the conferees here. Certainly thank you to Leanne and all the rest of the staff for all your help, and thank you for the committee taking time here on this very important issue. Appreciate it. Thank you, and we are adjourned.